sort of a new use case in treatment of patients with advanced gastric or gastroesophageal junction adenocarcinoma. And so I'm pleased to welcome Dr. Josep Tabanero, who's head of medical oncology at the Vall d'Hebron Barcelona University Hospital, to make the presentation.
Thank you very much, Dr. Oshirski. Good morning, everyone. First of all, I would like to thank the scientific committee on behalf of all my co-authors, the scientific committee as well as the press committee for allowing us to present the initial results of Keynote-062, a randomized phase 3 study evaluating the effect of Pembrolizumab in the first-line treatment for patients with gastric and gastroesophageal junction adenocarcinoma. Patients with gastric cancer and gastroesophageal cancer, when they have advanced disease, have really a very poor prognosis. And the current gastric and gastroesophageal junction guidelines recommend to treat these patients with a combination of a platinum and a fluoropyrimidine as a backbone chemotherapy in the first-line setting. Pembrolizumab has shown anti-tumor activity and manageable safety in patients with advanced gastric and gastroesophageal junction, especially in the refractory setting in patients with PD-L1 combined positive score more than 1. So the Keynote-062 study was an international, multi-center, randomized study, as mentioned, evaluating the role of Pembrolizumab in the first-line setting of patients with locally advanced or metastatic gastric or gastroesophageal adenocarcinoma, HER2 negative, and PD-L1, CPS1 positive. And patients were stratified for, according to the geographical region, the extent of the disease, and the chemotherapy backbone of the fluoropyrimidine that they receive. The study was aimed to include a total of 750 patients in 3 different arms. The first experimental arm was with Pembrolizumab at the recommended doses as monotherapy. The second experimental arm was a combination of Pembrolizumab at the recommended doses plus standard chemotherapy with cisplatin and a fluoropyrimidine, either 5-fluorouracil or capecitabine. And finally, the third arm, the control arm, was conventional chemotherapy plus placebo. Patients were treated until progression of the disease, unacceptable toxicity, or consent withdrawal. The primary endpoints of the study were overall survival and progression-free survival, and secondary endpoints included overall response rate and safety. This slide summarizes the most important statistical considerations of this complex study. In the hypotheses that are seen in the first row of the slide were tested first and in parallel. And only the remaining hypotheses in the second row could be only tested if the first hypothesis were demonstrated to be statistically significant. The final analysis of this study was planned to be done when 415 overall survival events were observed in the Pembrolizumab plus chemotherapy or the chemotherapy arms, all in patients with PD-L1 positive CPS more than 1. The study was considered to be met the primary endpoint if any of the overall survival or progression-free survival hypothesis was significant. And this was achieved with the first comparison, comparison of overall survival non-inferiority of Pembrolizumab versus chemotherapy in the CPS more than 1 population. Actually, I will start presenting the data for the comparison of Pembrolizumab versus chemotherapy. As mentioned before, the study met the primary endpoint. The analysis of non-inferiority for overall survival of Pembrolizumab versus chemotherapy was positive for Pembrolizumab with an upper bound of the 99.2% confidence interval for the hazard ratio of 1.80. This figure being lower than the pre-specified non-inferiority figure of 1.2. The hazard ratio was 0.91, and the median survival of the 2 arms were different. As you can see, the median survival of Pembrolizumab was 10.6 months, and the median survival for chemotherapy was 11.1 months. And at the 2-year survival rate favored also the Pembrolizumab arm, being 27% in those patients receiving Pembrolizumab and 19% in those patients receiving chemotherapy. In looking at the forest plot for potential subgroups of patients that could benefit more from the treatment, there were no major differences for the different subgroups according to the baseline characteristics and the stratification factors, except for perhaps a slight increase in the benefit of pembrolizumab over chemotherapy for the Asiatic population. If we focus now in the population of patients that had CPS more than 10, and this accounts around 37% of the patients of the total population included in the study, we can see even a more profound benefit for pembrolizumab over chemotherapy, with a hazard ratio of 0.69, a difference in the median survivals of 17.4 months for pembrolizumab and 10.8 months for chemotherapy, and the 2-year survival rate of 39% for pembrolizumab and 22% for chemotherapy. However, inferential analysis for the statistical hypothesis could not be done because of the stepwise statistical model that I mentioned before. If we look now at the comparison of pembrolizumab and chemotherapy versus chemotherapy, the study did not meet the primary endpoint of superiority of pembrolizumab plus chemotherapy over chemotherapy, although there was a trend for a better benefit in those patients receiving the combination, with the median of pembrolizumab being the median of pembrolizumab plus chemotherapy being 12.5 months, and the median for chemotherapy being 11.1 months. The same effect was seen in the population of patients with CPS more than 10, accounting again 37% of the patients, with a similar benefit in the hazard ratio or in the medians, as you can see in this slide. In looking at the treatment-related adverse events, when we compare patients that receive pembrolizumab with those patients that receive chemotherapy, actually patients receiving pembrolizumab had less any treatment-related adverse events, and also less grade 3, 5 events, and also less patients led to discontinuation because of treatment-related adverse events. When we do a comparison between those patients that receive pembrolizumab and chemotherapy with those that receive chemotherapy, you can see that the treatment-related adverse events were comparable, both any grade and grade 3 and 5 events. Around 22% of the patients that received pembrolizumab had any kind of immune-mediated and infusion reactions, mainly grade 1 and 2, and no new safety events were seen. To conclude, pembrolizumab was not inferior to chemotherapy for overall survival in patients with advanced gastric or gastroesophageal junction cancer with PD-L1 expression CPS1 equal or more than 1. There was a clinical meaningful improvement in overall survival for those patients that received pembrolizumab compared to those that received chemotherapy in the population of patients that was PD-L1 CPS more than 10. Pembrolizumab plus chemotherapy was not superior to chemotherapy in respect to overall survival in patients with advanced gastric and gastroesophageal junction cancer in the first-line setting. And finally, there was an improved safety profile with pembrolizumab over chemotherapy in this population of patients. Thank you for your attention.
Thank you, Giuseppe. So actually, I was asked to make a few remarks about this study in particular, having myself been a GI oncologist for about 30 years over here at the University of Chicago, having seen many of these patients. This is a tough disease to treat. The patients are often older, often frail, often malnourished. Really until just recently, the only available treatment has been standard cytotoxic chemotherapy, which of course is difficult to tolerate, as you just saw in the safety profile of the chemotherapy arms in this study. So this is a disease that's been in desperate need for new treatment approaches. There was a little bit of a glimmer of hope some years ago when it became clear that about 15% of patients with gastric cancer and gastroesophageal cancer had amplification of the HER2 gene, same gene that's amplified in breast cancer, and in fact that treating those patients with trastuzumab or Herceptin in combination with chemotherapy actually improved their overall survival, and trastuzumab is now FDA approved in that indication. but that's the minority of this population. Certainly, this study demonstrating the potential for immunotherapy to substantially improve the outcomes of these patients is really important. I want to make a brief comment about this concept of non-inferiority, which is oftentimes difficult to grasp. Basically what the non-inferiority study is showing is that, in essence, at the beginning of the study, the investigators declared that they were willing to accept the possibility that pembrolizumab could be at least 20% worse than chemotherapy and still consider it to be not inferior. That's a clinical assessment, not really a statistical assessment. The statistics then are set up to be able to determine whether or not that non-inferiority boundary is met or not. And in this case, you could see that the results did fall within the non-inferiority boundary. And so it's certainly reasonable to conclude, as the study did, that pembrolizumab is not inferior to chemotherapy. Does that mean it's better than chemotherapy? No, but it certainly seems to meet the pre-specified definition of not being worse, and together with a substantially improved safety profile, I think it would be pretty clear to me that this would be a preferred treatment for this patient population. It also seems to be fairly clear, although it's not so clear whether it met the traditional definition of statistical significance, but certainly clinically it seems to be quite clear that pembrolizumab is superior to chemotherapy in the high biomarker positive population, the CPS greater than or equal to 10. So, what I take away from this study is for patients with advanced gastric and gastroesophageal cancer, pembrolizumab should really, in many cases, replace chemotherapy as a first-line treatment for this population. It's certainly not worse. It may well be better. I think it's an open question as to why there was no additive benefit by combining pembrolizumab and chemotherapy. And I wonder, Josep, if you actually have a thought about that.
Yeah, thank you, Rick, because this is an excellent question. There are several factors that we are evaluating. First of all, the synergistic effect may be also chemotherapy dependent. And in this particular case, patients with gastric and gastroesophageal junction cancer are treated with a combination of cisplatin and fluoropyrimidine. And this is a little bit different of what we have in other diseases, except for squamous cell from head and neck cancer, where actually the backbone chemotherapy in some of the studies that are being presented as we speak show a benefit. But in this particular case, the population of patients have a different tumor origin. These are squamous cell carcinomas rather than adenocarcinomas. So we still have to do more studies to understand why with this chemotherapy backbone, actually we don't see a clear synergistic effect for superiority in overall survival.
Thanks. So now it's your turn to ask the